Hello, everybody. Good evening. I am Dr. Shinoy. I am the chair of the Early Career Psychiatrists Committee for Illinois Psychiatric Society, the district branch of APA. We're glad you are here. We have done a lot of background work and planning for this event. However, we wanted this event to be as informal as possible so as to allow for a good question and answer sessions. We have requested questions from registrants. We have a few questions that were sent to us, and me and Dr. Parikh will sometimes take turns going over asking questions. And also, participants are allowed to ask questions themselves if they wanted to at some point, or they can chat and send the questions either to everybody or to myself or to even Dr. Parikh, and we will make sure to try and cover that as part of the Q&A session. So with that, a little bit about the event is that we wanted to call it Open Doors to New Opportunities. This event was planned with the younger crowd in mind, but that said, it can be applicable to even people that have been in practice for a while. So we wanted to know a little bit about different practice settings, different career options. And if you are an early career psychiatrist, you've been into practice for about a year or two and wanted to consider a different job opportunity or a different career sphere, and if you wanted to know more about it, today's sessions hopefully will answer some of the questions that will help you make those decisions, or even if you wanted to consider these questions into your growth, professional and personal, both. Now, with that said, we are hoping that the session is recorded so it can be made available for future attendees as well. Some of them who registered will invariably ask for the link. So please keep that in mind. This could be residents, medical students, fellows, or even other practicing psychiatrists. And that said, I will begin with introductions of our panelists, and then we'll have a short segment thanking our sponsors, and then we will jump into the talk. First, we have Dr. Emmeline Hazaray, who is the medical director at Centene, also a psychiatrist at Teladoc, and previously used to work at a federal healthcare center. And thank you for joining us today. We have Dr. Aron Janssen, the vice chair at Lurie Children's, and today I learned that he is new to Chicago, so welcome to Chicago as well. And thank you for being here. We expect to see you more at IPS events as well going ahead. Thank you for joining. Dr. Tinwalla is our president-elect of IPS. That's the first thing I want to mention. And thank you for being here. He's also the medical director at Anthem BCBS. We'll also be asking questions about his prior stint with correctional psychiatry as well. And then Dr. Wadyal is the medical director for multiple services at Amita Health. And I think if you ask anybody on multiple social media groups, you would know that name because he's very caring of younger psychiatrists and answers their questions, whether it is medical or whether it is career-related questions. Thank you, Dr. Wadyal, for joining us. We will ask you a whole bunch of questions today. And finally, we have Dr. Johanna, who we all know, and I'm sure many of us would have attended talks by him. We are so glad you're able to make the time to come join us. And we also know IPS is honored to have you here. And thank you for joining. He is the interim chairman at the psychiatry department at University of Chicago. Thank you. And a little bit about myself. I'm Dr. Ishinoy. I am an early career psychiatrist, second year into practice, started practice in 2020, which was pretty interesting, learned a lot. I work at a place called Clarity Clinic as an employed child psychiatrist at that place, mostly outpatient. That said, we want to thank our sponsors, PRMS. Mr. Rich Stagnato is here. Please, we would like to hear from you.
Hi, thank you very much. It's great seeing everybody again. As you mentioned, we definitely saw some of the cool trivia events, and definitely was a good time. You guys know how to throw a good party. With PRMS, for those who don't know, we manage a psychiatry design, medical malpractice, and risk management insurance program. So we try to help you avoid any issues by trying to give advice when and if needed. By talking to risk managers on the phone. We provide ACCME accredited risk management courses. And also we have a library of information and resources available online, on demand, and personalized to your unique situation. Of course, we also do have an insurance policy available for those who do need it. You're free to check us out at prms.com. Or if you know colleagues who are interested, if they're just graduating this summer, we offer discounts as high as 80% for the first year out of a residency or a fellowship. And so definitely, if you refer folks to us, whether or not they buy the policy and they mention you as the person who referred them, we would provide a donation to any organization such as your great district branch. So just keep that in mind. And if anyone is going to APA, we are going to be doing our co-sponsoring of our reception as well. So keep an eye out for that if you're not getting slammed with other invites. And my colleagues will be running around all the other events as well. So I hope you see some of us there, and I hope you enjoy this evening's talks.
Thank you so much. We love the support that PRMS has been providing, and hopefully will continue to provide us with. Okay, so let's get into the main segment. And the first part of it is just an informal introduction, and we'll go one by one. What we would like to know is a little bit about yourself, your training, career snapshots, and what do you like to do outside of work, and what are you looking forward to doing this summer? Because it's been a long couple of years with the pandemic, so we also want to know you. So let's begin with Dr. Hazaray. We're going to go in now alphabetical order. So thank you. Dr. Hazaray, you are muted. Can you please unmute?
Thank you so much for having me. My name is Dr. Emmeline Hazaray. I'm both certified child and adolescent psychiatrist as well as in general psychiatry. I started my career in medicine as a pediatrician in private practice. After moving to Toronto from India, I joined University of Toronto and Hospital for Sick Kids as a research fellow in pediatrics. Midway, I relocated to Indianapolis, Indiana, and therefore joined Indiana University to complete a general psychiatry residency, as well as 2 fellowships, one in child and adolescent psychiatry and one in clinical psychopharm. On completion of my fellowships, I was appointed as the juvenile hall child psychiatrist at Santa Clara County in San Jose, California. And I simultaneously also worked as a residential psychiatrist for a nonprofit in Los Gatos, California. Following that, I moved back to the Midwest, to Chicago, and had a stint in private practice as a child psychiatrist as well as an adult psychiatrist. A few years later, I joined the Federal Healthcare Center as a psychiatrist to treat children and adolescent dependents of active duty and service members, as well as active duty servicemen and veterans. Just prior to joining Lovell, the Federal Healthcare Center, Captain James A. Lovell in North Chicago, they had merged their resources in 2010 with the integration of the Naval Health Clinic and the North Chicago Veterans Administration. And their goal was readying warriors and caring for heroes. So preparing active duty for deployment and treatment of veterans after they returned from deployment and were no longer in active service. Traditionally, the DoD and VA have a long history of collaboration in providing all their dependent beneficiaries very separately care. But following this integration, which was a pilot, there have been multiple such affiliations between the DoD and VA all across the nation. But the advantage of FHCC was that it was the only one that also had a pediatric clinic within the facility. So this was, served two goals. One was to treat the dependent children. We got all our referrals from the pediatric clinic, and it was a great opportunity for integrated care between the two services. The second goal was to set up didactics and education of Rosalind Franklin University residents in the child clinic, as well as didactics in child psychiatry at Rosalind Franklin itself. I became the chairperson of the Psychiatry Evaluation Committee, and I rose to the rank of associate professor. It was in 2020 that I decided that I needed to now, branch out, and that's when I joined a managed care company, and I also decided to go into telehealth practice. So with the result, I completely worked remotely. And so that's, I have a lot of things to talk about the federal facilities, because, that's one need that all across the US, that our service members and veterans need the care after all the sacrifices that they have made for the country. And that's my story. Thank you so much.
Thank you. Thank you so much for that. What are you looking forward to do this summer?
I'll be traveling. My son is graduating with an MBA from Oxford in London. So since I have to travel to London, we plan on also going to Spain.
I'm glad. Congratulations to your son, and I hope you have a good trip. Okay, so thank you, Dr. Hazaray. Next, we go to Dr. Janssen.
Hi, everybody. It's great to see some faces and some new faces. As Sid mentioned, I'm relatively new to Chicago. I'm not really new because I've been here now a little over 3 years. But I came here, had my second baby, and then COVID hit. So it feels like it was yesterday in some ways, and it feels like it was about 20 years in other ways. Chicago's always had a very special place in my heart, and I kind of had a roundabout way to get into child psychiatry. And I think it's probably the easiest way to talk about how I ended up doing what I'm doing. So I went to medical school in Colorado, but before I decided to do medicine, I was really debating whether or not I wanted to pursue this as a field at all. I graduated from college in Colorado and kind of on a whim actually moved out to Chicago to live for a year because I didn't know what I wanted to do. Ended up working at Howard Brown, which is an LGBT FQHC or health center, and having the experience of these doctors who are working with this underserved population that was kind of near and dear to my heart was all that it took to really convince me that this was the field that I wanted to be in. So I went back to Colorado for medical school, surprised myself by realizing that I actually liked kids. I was the youngest in my entire extended family, so was never around kids growing up, and found it to be shocking that I really enjoyed the work. And so knew I was going to do pediatric work in some capacity or another. Found psychiatry and really knew that that's where I was going to head. So I did my training all at NYU, where I did my adult and my child psychiatry fellowship. And while I was there, I was a good resident. You know, I did the things that you're supposed to do. I checked off the boxes. I made sure I was getting good reviews. And by the end of my second year, I was kind of refreshing the consulting gig websites like every week, really feeling burnt out, really feeling like I didn't know what I was doing or why I was here, and really disconnected from that sense of what brought me into medicine in the first place. And I got a kind of kick in the ass by my then boyfriend, now husband, who was like, what are you waiting for? Right? If you have a sense of what you want to do, why aren't you doing it? And for me, that experience working at Howard Brown in Chicago, working with this underserved population, was what I wanted to do. And I found myself kind of doing what was expected of me as opposed to doing what I was really interested in doing. And so I just started finding mentors. And if they weren't at my own institution, I just reached out to folks across the country who were doing this work, and really had the experience of learning how to focus on transgender youth in particular. And so when I started my fellowship, I was just very clear about having this interest. And I was lucky enough to have a program director at the time who was a yes and kind of person, who could say, we don't have the expertise, but I'm really excited about this work. What can we do to help support you to learn what you need to learn in order to do this work and build a path for yourself? And so that to me was really appealing. I've always been a person who likes to be told no, who likes to be able to build new things and break down barriers. And so to be able to pursue a field that at the time, this is 15 years ago at this point, was really in a different spot that it was in now. My goal was always looking back to that kind of community health experience and kind of this idea of working in the community and kind of being in the trenches. But the more that I did work, the more that I recognized that to be able to get in the rooms where policies were made, to really make impacts on healthcare outcomes, I had to understand the population more. And so I was not a researcher by training. I'm not a researcher by temperament, but I recognized that I needed to start doing some of that work in order to really get into those rooms where I wanted to be. And so that's what I started doing. I just kind of found some colleagues who were doing similar work and started small with some kind of basic chart review kind of things. But it was having that expertise and that passion, which was only a part of what I did, right? I also ended up running our consult service and did a lot of educational work and had a private practice through the faculty group. But I had this niche and I had this interest where I could dig deep in and really become an expert. And that has kind of made all the difference, both in terms of getting through those days where the work is tough because the meaning is there, but also opening up opportunities, right? Nobody would have expected in 2011, when I first started my clinic for transgender kids, that this was going to be something that was useful to a career in academics. The word at the time with my hospital system was, we're gonna support you, but we're not gonna kind of publicize this. but that's fine, right? That was a perfectly fine place for me to be able to take the space to be able to figure out who I am and how I practice and really build up this clinical work. And so 3 years ago, after having kind of trained enough people to be able to take over that clinic and kind of getting it to a place where I knew it was be sustaining, I took off for my next adventure as vice chair here at Lurie Children's. It's a really exciting place to work. We're hiring, by the way. We're very excited. So if anybody's interested and wants a career change, let me know. But I get to continue to do some of the work with transgender youth, which kind of gets me to the question about what I'm looking forward to over the summer. So here's kind of one of the secret advantages of having an academic interest, is that every once in a while conferences in Madrid and Amsterdam and Hong Kong will reach out and say, hey, do you want to present? And I get to say, yes, absolutely. I would love to. So I'm going to Spain this summer as well. Unfortunately, couldn't convince the family to come with, but it'll actually be nice to get away. So thanks for having me.
Thank you so much. At a later point, I will also ask about your book, Dr. Janssen. Okay, who's next? Dr. Tinwalla.
Thank you, Sid. So Abdi Tinwalla, let me start by, I think, going back to my bachelor days. I got my bachelor's in pharmacy in India. I'm from Bombay. I came here, I got my master's in pharmacy, went to medical school in Ohio, in Toledo. Couldn't stay away from Chicago because my wife's family is from Chicago. So came back to Chicago for my residency. I did my residency at Rush. I got interested while in my residency. I got interested with sex offender treatment because I had some patients, young patients, who were being charged with sex offenses. And, it was very hard at that point to find some good treatment for them. That's when I got interested in the field. I started looking around. I did some grand rounds on it. So I went up to upstate New York in Rochester to do my forensic fellowship. Again, graduated from there, came back to Chicago. I started working with the SVP population, which is the sexually violent person population in Illinois. It's a special law that some states have where people, after they finish their criminal sentence, get civilly committed indefinitely for treatment. We started with a program of about 100 people. Right now, we have about 600 of the most violent, sexually violent person locked up in a treatment facility in Rushville, which is about maybe 4 hours away from you. That is something I started when I came back from my fellowship. I was doing that for about a couple of years. I got an invitation to join Wexford Health, which is a correctional healthcare company, which contracts with different states to provide healthcare system to the correctional facilities in their state. I joined them as the chief of psychiatry. And I did that for about 10 years. It was too long. Got to travel around the country, explore different states and all the Department of Correction, went to all the different prisons. It was a good life for 10 years. But after 10 years, I started getting burnt out. I think most of you can kind of relate to that. After doing it for 10 years, you feel like, okay, you have done it all. You want to do something different. While doing that, I got an invitation to join a managed care company as a consultant. So I started doing that part-time, and eventually I fell in love with the job. As Dr. Hazaray said, it is working from home. You have, you can have your own schedule. You do whatever you want. As long as the work is done, people are happy. So I worked with Molina first. Then I joined Centene. And when I joined Centene full-time. So I transitioned from my correctional healthcare company to the Centene and working as the chief of psychiatry. Did that for about 2 years. And then I transitioned to Anthem. It was just a better opportunity, a better company. I guess, in my opinion, it's a better company. I transitioned to Anthem, and I've been with them for the past 3 years. Well, along with that, I think I wear a lot of different hats. I'm also the president-elect of IPS. I got involved with IPS as a counselor. I then moved up into the treasurer's role for about 2 years. And last year, I was the president-elect to be the president in a few days. Thanks to Dr. Weinstein. He was on, but now there he is. He's still there. Then what else? I also got my MBA in finance and executive physician management from Kelly School of Business. I got that in 2020, which I would definitely recommend to people if they are interested in management position. In terms of my plans for July, I'm planning to go to Iceland. I've been to Spain, I loved it, but this time I think I'm going to Iceland. And that's me in a nutshell. I'm sorry, that's a concise version.
That is so helpful, and thank you for your leadership, Dr. Tinwalla. I'll also take a moment to say thank you to Dr. Weinstein, who has been spearheading IPS, and thank you for letting us have this event.
It's a wonderful event. Pleased to be here.
Thank you. Okay, so we move on to our next panelist, Dr. Wadyal.
Hi, good evening, everyone. My name is Wadyal. You'll see Shubhrajan on there, which is actually Hindi for I want to make my son's life difficult. But everyone calls me Raj. I was born in New York City. That's why you see an Indian guy with a Ray Romano accent in front of you. And was the son of a veterinarian who was the son of a veterinarian who was the son of a veterinarian. So the plan was that I was going to be a fourth generation veterinarian. I went off to college and I spent my entire childhood cleaning cages. I applied to veterinary school. I got into Cornell, but I think that's because my dad was president of the New York State Veterinary Society. And I decided not to go. Instead, I went to a Caribbean med school. My father, lovingly called it Club Med, the American University of the Caribbean in St. Martin. And thereby became the first Indian kid in the history of Indian kids to irritate their parents by going to medical school. And went off to med school, decided to double down on upsetting my parents and decided to become a child psychiatrist. I met my wife while I was there. She is an OBGYN. She graduated a year before me and she matched at Louisiana State University. So for a New York guy, I'm married to this lady, a Southern belle from Deep East Texas, and she matched first. I did my fourth year of rotations at LSU, and they decided to let me hang around. I did 4 years there. I was the chief resident, subsequently stayed on for fellowship there, was thinking about going elsewhere. But at that time, I had two daughters who were 13 months apart. So I had a newborn and a 13-month-old and an OB wife. So I needed to not uplift things at that moment. And one of the rotations I was most dreading in fellowship was the research rotation. So I went to the research coordinator and said, which one of these requires the least clinical time? And they said, well, the one on autism, the patients don't want to talk. You'll be in and out of it. I said, great, I'll do that. And I got enrolled in a couple of studies for autism, and I fell in love with treating these kids. I was so taken aback by how much these families needed help and how little help there was. So I completed my fellowship and I was talking to my wife and my parents, and I said, I think I want to work with kids on the spectrum, but it's so hard. And my dad looked me in the eye, and this actually struck up as he passed recently. He said, nothing worth doing is easy. So I love Chicago because it's like New York, only with nice people and it's clean. So we moved up here. My sister had already lived here. And Amita Health interviewed me. It was Alexian Brothers at the time. It was Amita, and last week we became Ascension. So I'll let you know what the name is next week. It's a big conglomerate. And they had just lost 3 child psychiatrists and were desperate. So I was in a place where I could bargain from power. And they said, well, what is it going to take? I said, well, I have 2 kids and a third on the way. So I need an OB job for my wife where she doesn't take call more than once a month. I need salary X, Y, and Z. And I need the ability to start an autism treatment center. And they said, done. So I signed that day. We started with an office that was the size of a closet. We now have one of the larger autism treatment centers in the Midwest, where that's the entirety of the outpatient work. I've been dubbed a workaholic by a lot of my peers. I don't recommend people follow me, but I do work probably about 70, 80 hours a week between administrative roles and inpatient. So I do inpatient child and adolescent for Amita Health, and I'm the medical director there. I am medical director of our group, which encompasses about 120 psychiatrists across Chicagoland, and medical director of autism services. So I stay busy. And I love my job. I am not an academic. I may have upset Dr. Janssen's residents and fellows recently because I sent a few patients his way. I'm sorry, I haven't called them all back yet. And I kind of specialize in taking on the cases that no one wants. And I think I have the coolest job in the world. I work on a productivity basis, which is something I recommend because I can take all the vacation I want. I love to travel. It's what I live for. In the last year, I've been to Dubai, Switzerland, the Caymans, Bahamas, got back from the Caymans again, Spain last summer, and Gibraltar. And I think Spain is a theme because this summer, my family and I are planning a trip to Tenerife in the Canary Islands, which is part of Spain. So we all have great taste in travel.
Thank you, Dr. Wadyal. That was wonderful. And you should look at the comment at the chat. We have a very interesting comment. But anyway, so we'll move on to our next panelist, Dr. Johanna. Thank you again for being here.
Oh, thank you, Sid. And Dr. Wadyal, I could see why you're a social media star. You have a great presentation. Well, I'm Dan Johanna. I am the interim chair at the University of Chicago. And I'm a little older than everyone. I've been around for a while, but I graduated medical school at Rush in 1982 and a residency at Northwestern in 86. I was on the faculty there for 19 years. And I would say that I'm trained as a community psychiatrist. All of my mentors were community psychiatrists, which is basically involved in serious mental illness, severe mental illness, and population management. People like Harold Vysotsky, who was the director of mental health in Illinois, Eric Plout, who was director of mental health in Connecticut, High Pomp, Jerry Dinson, who started Thresholds. So these are my mentors, and got me interested in the treatment of severely mentally ill and in how to make population changes. So I know Sid wanted me to talk a little bit about administration, and in order really to make those kinds of large changes, you have to be involved in administration and in organized medicine. I'd like to think that the Illinois Psychiatric Society and others that we've made some inroads in making some good changes for people. I'm also boarded in forensic psychiatry, since many of my patients wound up in jails and prison, which Dr. Tinwalla knows. And so part of this work is to work in that population. So what happens if you're interested in community psychiatry, you wind up doing some administration. I was director started as an emergency service, psychiatry service director, inpatient director, and then inpatient and outpatient director, then a practice plan for academic faculty. And eventually now I was vice chair, and now I'm chair of my department. There are about 260 total people you have to worry about, including about 45, 50 faculty, research assistants, front staff, just everybody. It's been particularly difficult doing this by Zoom. You know, we are by nature psychiatrists, we're social beings, and this has been a difficult period, not being social as we'd like to be. my research is in what is called, I didn't know it was a name. I thought I was just starting stuff, but it's called implementation science. So we know how to do, we learn how to do things in demonstration projects, but how to put them into practice, the implementation part turns out to be a lot harder than, you can always show something works in a demonstration, but then how do you get it to work? And I've lately been training federally qualified healthcare centers, free and charitable clinics around the country to integrate behavioral health, since many of our patients wind up in those settings, either for lack of funding or being immigration status. And so it's a very interesting group to work with. So I would say that's what I do. This summer, I'm probably going to do what I've done all year, which is stay here. And I, as a hobby, I'm a drummer in 2 rock bands. So we'll be playing out. And every Thursday, I'm the house drummer for a pro blues jam, except the 3rd Thursday of the month, which is why I'm here. Or as the band calls it, the 3rd Thursday, since we don't get to play.
Thank you so much. I did not have the slightest clue of the last few sentences coming in this way, which is wonderful.
Well, we're on Spotify. 6FM is one of the bands. We're on Spotify. A lot of covers, so don't sue me.
We always knew you were a rock star, but now confirmed. So thank you. Okay, so with this introduction, I would like for the audience to understand that we have a very diverse panel. Also, a big shout out to Dr. Amber May, who's here, who's also part of the ECP committee, who helps us put these things together. Dr. Karen Pierce is here, who's one of my favorite mentors when it comes to advocacy and ACAP related matters. So with that, I'll open up the floor to anyone that would like to begin the discussion with questions. And also, dear panelists, please, if there are questions that are important that you think should be asked, please feel free to guide us with the questions that the ECPs should be asking, and please go on to help in making this a resource for current and future viewers. So the floor is open for any questions.
Well, maybe I can make a quick comment so get people going. I mean, you heard from this panel just how diverse the field is. I mean, you could do practically anything for all you ECP folks. You could do pharmacology. There's pharmacologists on board, child psychiatry, areas of underserved people, administration. You can work with, some people work with corporations and work with groups. We are experts in groups and in group dynamics. You can do individual treatment in your office. And these days you could stay home and make a living. It's really, really remarkable. And I think, like Dr. Wadyal said, it's a great, you'll love this field, I hope. If you don't, that you should find something in it that you love. So with that, please ask us questions.
So I know Dr. Parikh also has questions. I saw a hand raised up. Dr. Jasleen Singh, who's also our RFM committee chair. Please.
Hello. So I'm a little bit pre-ECP, I guess I would say. But I guess one question I had kind of to go off of what Dr. Johanna was saying is in terms of there being so much diversity, and I know like from hearing different stories or even just talking to other attendings that there's a lot of like bouncing around until people find like what they decide to maybe pursue or do longer term. Do you have any recommendations in terms of like how to figure that out and go kind of about like, is it going to be private practice? Is it going to be working with a residency program? Is it going to be working with veterans and kind of figuring out how to navigate that, I guess?
So Justine, I would say, if I can start off by saying, I would go with what your interests are. If you have some interest, I would pursue that. As I mentioned in my residency, I developed an interest in the treatment of sex offenders. I pursued that, and then I still do actually. It's funny. Somebody was saying, I think it was Dr. Wadyal who said he works 70 to 80 hours. I think I'm close competition, if not more, for him. I have like 3 different jobs that I do, and I try to keep things diverse. Because, if you have an interest in something, you'll keep doing it and it doesn't feel like work, right? So that's what I do. I've still continued my sex offender work that I did. I do it on the weekends now, but I still do it because I enjoy that work. So start off with something that you enjoy, and then other opportunities will come your way. And always keep in mind, one thing I always tell people that I talk to is keep a work-life balance. Because I work from home, I'm able to work 7 days a week, because 5 days a week I'm sitting at home on my computer table, just working from home. So having that work-life balance, I think, is very important.
Well, I'm going to talk about the forbidden. I'm going to talk about money. Okay. I think you have to be honest with yourself. What do you want out of your career? Do you want a career in public service with the understanding that if you devote yourself to education or to some underserved communities, that you're going to be paid remarkably less, and you might work more for a lot less? So, it's commendable, but I'll be completely forthright. I was drowning in student loans, and I didn't want to do that anymore. I didn't want my wife to work constantly. So I tried to find the path where I could serve a community and work for a nonprofit health system, but also make sure I got paid. And the truth is, in this field, there's a dirty little secret. If you work like a neurosurgeon, you'll get paid like one. It's not for everyone, but if you can take a bunch of administrative roles and you can show your value and create a niche, like myself, it was autism. With Dr. Janssen, it was the LGBTQ community. Find where you love and create a niche where you're somewhat hard to replace, and work like a dog. Take the cases no one will take, and make sure that you don't take a salary. Make sure that you're getting paid for everything you do. Now, again, it's going to be unpopular, but I think it's true. If we have young people now coming out of training with upwards of $600,000 worth of debt, and if we're going to say that it's hard not to walk around with that weighing on you while you're trying to start a family, start a life, build a practice, I think you'd be lying to yourself. Now, if you're independently wealthy, or you feel like you don't have that problem and you want to go take a job that is not as high impact or has the ability to serve the community maybe a little bit more, fantastic. Dr. Hazaray's work with our veterans, Dr. Tinwalla, the work you do with the patients that most of us would run screaming from, you're doing God's work in my eyes. But I answer to a higher power. That's a wife and 3 daughters. So they have expectations on life. So I think we don't talk about it enough. We don't talk about how much we get for an RVU. We don't talk about how we negotiate contracts. And we have a bunch of people who got not an MBA from Kelly, but an MBA from a no-name school with an RN degree, who are our bosses and make triple our salary. How the heck did we get there? The truth is, we're the only thing besides the nurses in the hospital that's truly bringing value in terms of the bottom line. Now, obviously, they bring value in other ways. Don't forget that, and negotiate that way. They will make you feel like you're an early career psychiatrist, don't know what you're talking about. Come in with the MGMA numbers and come in hard. And I say this as someone who hires people. It's not in my best interest sometimes to say this, but it's true. If you want to make 400, 500, 600 more than that a year, you can. And I don't know why we pretend that it's not a real issue, but for me, coming out of training, burdened in debt, trying to start a family, it was a huge issue.
So, Dr. Wadyal, to your comment on money, I think money is important. I totally agree with you. I can tell you when I graduated residency, we were looking at making about 180 to 200 a year. You would be happy. Right now, I used to recruit for Wexford a lot in terms of correctional psychiatry. I used to recruit for them a lot. And we were paying upwards of $200-300 an hour for people to go into the correctional facility. I mean, when you compute that amount, it comes out to be $600,000-700,000 a year. So I think the salary is there, to be honest. I think this is the time, I call this the golden era of psychiatry. Because for people who want to make money, I think money is to be made. But I think there is a balance between the two, to be honest. I mean, of course, I'm going to say that I've got myself in a position where I make enough money based on what you just said, bringing value to the program. But I think you also have to appreciate and like what you do, because quite often I've met people who come into corrections for the money, because there is money. But within a year or two, they're just gone because it's not something that they thought they could do or they're not fit for it, right? So I think having that fit along with the money, I think is very important. You have to always enjoy what you do. I think the money will come. As you establish yourself, as you grow, I think the money will come. I think that will come naturally, I think, with time. And then we are here, right? Agree. And we are here to help these, to guide people in terms of negotiation. Sorry.
No, I think you're completely right. You could offer me $400 an hour and I wouldn't do your job. So yeah, I completely agree. You should certainly like the work, but the variety of work available, nearly any field of psychiatry that you go into, there's more demand than there are, practitioners. That's why there's a large push to replace us by people with online NP degrees. And so we have to remember we hold more value than that, and we should negotiate accordingly.
The only thing I would add to your question, Jasleen, I mean, get as much exposure as you can. Everybody, I feel like, is going to tell you do what you love, but don't neglect what you dislike and what really bothers you about the work, because you have to do that too. And if it's really getting to you, it can be the best job in the world, right? I always assumed I was going to be at Bellevue where I trained, but the act of doing treatment plans by hand every 3 months and tracking them down and having them signed by, it was just infuriating. I was like, it's not worth it for me. And it was one of the things, and I feel bad saying that, but I'm like, this is going to be a real impairment in my experience of this job if I have to do these inane things. And so you got to understand kind of what are those aspects of the job that you don't like and minimize those as well.
Can I add another thing in listening to all of you guys? The other thing is often our jobs are a journey. It's not a corporate ladder like people in business. I can tell you how many different jobs I've had over the years, depending on it. And that's the beauty of our training and the depth of our training. So, we don't always have to stick to one, I mean, Dan, it sounds like, your chair, oh my gosh, you did the corporate track, but you did a lot of zigzagging in order to get there. And I think that one of the things that I love about being a psychiatrist is there are so many different things to be. And I think in life will bring you very different challenges at different times. I had to be a breadwinner for several years. Man, I didn't like that. I feel really grateful for breadwinners. But it just changes, but I could. And so I think that's the other thing to keep in mind. There's many things you can do with this degree.
I, for one, think that one should be flexible and, be ready to work hard at whatever job comes your way, because initially you never know what you're going to enjoy. And I've enjoyed every position that I've held. Right from working with youth in a juvenile facility. I worked with kids who were removed from their parental care and became wards of the state. And I enjoyed working in that residential facility. I loved working at FHCC because, for one thing, I could practice child psychiatry there. And I also liked working with active duty. I not only was responsible for treatment, but also for doing their medical boards, their pre-deployment, post-deployment evaluations. I also had the ability to participate in a lot of committees within the hospital itself. And then very importantly, I was able to also get into academic psychiatry and teach residents. In fact, I'm seeing one of my ex-residents that is here today. And so, I think I love doing what I'm doing right now. And, I have no complaints about not being able to travel or finding a parking spot in a hospital or anything. So I think one has to be flexible. One has to, acquire skills that you may never have had the opportunity to see if that was something. During part of my initial medical career, I was a ghost writer for a company that did the write-ups for all clinical studies. In fact, the first write-up I did was for Ambien, for amoxicillin and all those. So I think as a psychiatrist, you never know what's going to interest you. And if you find that you no longer feel interested in that, it's time to move on and pursue something different. So that's been my experience.
So that was a wonderful opening question. And I know we touched upon topics that usually doesn't get discussed, including finances, money, student loans, and all that. We ECPs really like to hear those things. So yes, I know I interrupted, please. Was there anyone else that was going to comment on that question?
I might as well round out the table. I think, well, money is important. You're in the best time now to make money as a psychiatrist. The demand, as Dr. Tinwalla said, is enormous. And so almost anything you do, you should be well reimbursed. And I know, I hope your mentors are training you in negotiating with people like me and Dr. Wadyal. So, because you can really negotiate for a higher salary. And so we're in great demand. There's never enough of us. And our background and education is unique. So I would say one more thing. When you come out, I mean, the first thing to do is to develop your chops, going back to my drumming, but you got to develop your chops. You got to be good at, get good experience and be good at what you do. And the money, I think, will come. That's my feeling.
No, that is wonderful to hear. And
Hey, Sid,
yes.
One thing I'll add, if somebody in this group is not making over 300 right now, please reach out to one of us. There's definitely, I'm hoping psychiatrists are making in this day and age over 300 at least.
I'm pretty sure there are quite a few of us who will reach out. And I can see a couple.
I can top his numbers.
That is wonderful to hear. It's very encouraging, which is a perfect segue to ask our next question, which came as from one of our registrants. Where do you see the profession as a whole going? Because the trends seem to be scary at times with multiple scope of practice issues, jobs that require you to have mid-level supervision as a mandatory thing, and seems to be there seems to be blurring of lines between who is a psychiatrist and who is not, and that worries many ECPs about their career 5 to 10 years from now. Anyone wants to take a jab at that?
I'm happy to take a jab because I have an unpopular opinion and would get pilloried on every psychiatry group known to man for this opinion. But there is a demand that we cannot meet. It is impossible to meet. Right? There are 1 million kids in the Chicago metro area. 20% of them are going to have some sort of mental health condition that requires treatment. That's 200,000 kids. we don't have the capacity to see everybody that we need to see. So we have options, right? We have two options. We build our expertise and we use that expertise to teach other providers, namely pediatricians, that's what we're going to advocate for, to be able to start doing the intervention, prevention work, and start recognizing mental health disorders and treat kids earlier so that we're preventing the care. Or we recognize that our system is broken and we try and optimize the system as it is, right? So we can do everything that we want, but as long as there's this crushing demand, there is going to be folks that fill that demand. And so it's a really complicated ethical question about where mid-levels fall and what our responsibilities are. But we as psychiatrists have such a value that is never going to be taken away, right? There's never going to be a mid-level that's going to replace the level of expertise, knowledge, and working skills that we have. And we can't undersell ourselves, right? We can't settle. But it doesn't mean that we can't also recognize that there is a major problem to access to care, and that as a profession, there are, unpopular opinion again, everybody can do their own work, but as a profession, there's too many of us that go into private practice and have not enough opportunities for folks to seek care. And so it's a tricky situation. I don't have an answer for it, but I think just saying no is also not an answer either.
I'm in your camp, Dr. Janssen. I think in my career, I trained primary care docs and we trained pediatricians. And in fact, although we have argued about psychology, prescription privileges, we tried to make that as safe as possible. But I do collaborative care all day. I work with case managers, and they can be trained to identify, to be the liaison with primary care, to do some basic behavioral health interventions. And in an hour, I could help move care for maybe 20, 25 people. So I agree. I think, if you look at cultural psychiatry or cultural mental health around the world, it's community people who work in their own communities, who have lived experience in their communities, that you train to help them. I don't know how far down the ladder will go, but we're training people in violence prevention in their communities. I mean, that's part of our work. And so I think I totally agree. Private practice, you could fill your private practice, but I think we don't do the community as much good as we could.
So just to jump in on that, and I think in at least in corrections, what I've seen in correctional psychiatry, we had a shortage of psychiatrists coming and working in corrections. We had to go to nurse practitioners and PAs. In my experience, and I do the peer reviews for all the psychiatrists in DOC in corrections in Illinois. I did about 80 of them just in the last couple of months, and I reviewed them. I reviewed their charts, I reviewed the work. In my experience, some of them are really good, some of them are not good. They are very good with basic depression and anxiety, but when it comes to more complicated, schizoaffective, mixed with PTSD, trauma, substance use, I think they struggle in terms of prescribing. I think what they need is proper supervision, proper guidance. They can do a decent job with most of the conditions. There may be patients when they need to understand the limitations when they need consultation with psychiatrists. But I think as you pointed, I think as all the speakers are pointing out, it is inevitable that we will have other people jumping in and needing to do the work that we need them to do. I think the best we can do is to make sure that it's safe for our patients and it's done appropriately.
I couldn't agree more.
I'm actually of the same camp. We do have to do team-based care. The problem has been more the structure of it, that our liability, there is no liability insurance on any other mid-level person unless they're hired by the system. And so our license ends up being abused and used by other places in clinics, not in medical centers where there's a structure and a way to do that. And until they do medical education and that people who prescribe are under the Department of Medical and have to have malpractice and have to have responsibility, then I think we're putting many physicians in practice out in communities at risk because it is our license that's doing it. In fact, my malpractice insurance today just came out with saying collaborative care. When you're a collaborative care consultant, you are at very high risk for the liability with it. And yes, I do think team-based care is here, but if we don't change the structure of responsibility and liability, especially in Illinois as a tort state, we're going to be in trouble.
You know, I mentioned that I grew up in an animal hospital. So I wanted to be a dog groomer to make extra money in my dad's office, but I couldn't get the license in New York State. It required 800 hours of clinical experience. To be a nurse practitioner in the state, it requires 500. So you can take care of these very at-risk kids with less training than a dog groomer. And we clean up their messes all the time. I tried to do collaborative care with some NPs. I'm probably one of the few psychiatrists in my group who does not have a quote unquote collaborative NP because I kept on actually checking their work and kept on making them fix it, and they all quit. When I said, hey, you got to check lipids and you got to check A1C. Do I have to? Why? Because it's the standard of care. And I have had much better luck working with pediatricians and internal medicine physicians in my system who have a basic understanding of medicine and who provide outstanding care. My wife's a gynecologist. She takes on a lot of the kids with autism because no one else will take them, and I make her. We work for a separate system, so I don't have any financial thing in that. And she likes to, her joke is I'm a gynecologist because I have to, she deals with a lot of basic depression. And I think she does a great job. I'm slightly biased. And I have multiple physicians from across the state, pediatricians will say, I've got this going on. My kid can't drive 4 hours to see you. What do I do? And they pick it up very quickly.
Thank you for that. I know advocacy is a really important topic, but in the interest of time, we'll be moving on to our next question. Dr. Parikh, you had a question?
I had in order to help Dr. Shenoy, I had thought of like a lot of questions that I will ask, but it's been a wonderful group. We have a lot of like just the talk and activities going on, and I enjoy it all. It seems like we're going to start a petition to change the SAGME residency rule of like 80 hours, since 7 to 80 seems like a norm after the residency. Why don't we go back above 80 for the residents? I'm just joking. I've gone through like all of those phases of like just working harder, even before residency, and continue to like still work. Probably not 70 to 80, that's just impossible as of now with the little kids. But whenever I get an opportunity, I would get to 70, 80. But I just don't know that like whether any of the trainees, like any of you who have, if you've been around the trainees, like we all know that like that number, that when we say that like you should be working for like 70, 80, it just doesn't like they just cannot relate. And then like to some extent, I was one of those people too that like, what's wrong with that? Like we should be working hard. And I still think so, but like it's just having kids, being in like just that kind of the life phase, it's just hard. Like I don't think I mean I can do justice to my kids if I'm working 70 to 80. So yeah. What I'm hearing, I want to not feel guilty about it. And I see Dr. Janssen already said that no to 70 hours.
Yeah, I don't feel guilty.
Yeah. And by choice, it's all okay. Like by choice, and like just probably getting to the point that like where you are making a conscious decision and this is working out with the life, like that all makes sense. But otherwise, it's kind of a hard number.
Yeah.
So Dr. Parikh, if I can jump in, I honestly believe that, that 70, 80 hours is just a number. I work about 70 to 80 hours a week, I'll be honest. I'll tell you the things I do. I'm IPS president-elect. I work with the sex offenders. I teach Northwestern fellows. I work for Anthem full-time. I've got all these different things I wear. I work about 70 to 80 hours. I think Steve will vouch for that we have put in a lot of hours. But if it's something that you enjoy, it doesn't feel like work, first of all, I'll be honest. Second thing, working from home has its privileges. You don't get tired at the end of 5 o'clock. Some days, yeah, they are stressful. But for the most part, even like right now, I'm still full, I'm hyper. I'm all ready to go to the gym after this and work out, you know? So it doesn't feel like work when you're really like enjoying it and working from home. I think I talk a lot about work-life balance. And if any of you want to talk about working from home and how it feels, reach out to me afterwards and I'll help you out. It works out very good. I think Dr. Hazaray also works from home. She mentioned the work-life balance. I think as long as we do, and I think Dr. Pierce works from home, there are a lot of people are working from home. And as long as you can do it and have a good work-life balance, it's perfectly doable.
Okay, so here I'll make a pitch for the not making as much money, but not having a turnkey business where every hour you put in, you get paid. There is a nice thing about being on salary in an academic setting is that you get 4 weeks a year of vacation, 2 weeks a year of conference. We send you to paid for your conference, pay for your license, pay for your malpractice, pay for your office, pay for your computer. You can see any kind of patient you want. And so you may not make as much, but I would say there's something about not having what's called a turnkey practice where you gotta open one of your bedrooms turned into an office. So there's something advantage. And as a chair, I don't make anybody work that kind of hours. I mean, I want people to have a good life.
Can I ask a question, Dr. Shenoy?
Yes, Dr. Lancaster.
So I agree, you know, there is so much in psychiatry. It's a cornucopia. There are times though when it's hard to figure out what the next steps are for all of us, right? Can the panelists talk about times when they've weren't sure what to do and how they worked it out? And if they talk to people, if they read, if they went online, you know, prayed about it, I think transitions are really important as we're looking for changes. And how does that happen?
So I think for me, I do a lot of networking on LinkedIn. I'm very active on LinkedIn. I get a lot of opportunities coming to me on LinkedIn. And even right now, you know, I'm with Anthem. I'm happy with a full-time job with them. But if something comes my way, I'm always interviewing. I'm always looking into it to see what the next opportunity is going to look like. I never shut the door and say, no, I'm fine. I'm happy where I am. It's always good to look. So I think networking, any media, whether it's Twitter, whether it's LinkedIn, or wherever you're networking, I think it's a good way to be aware of what's out there. And then if something comes and if it strikes your fancy, why not try it? I mean, you know, I would always say, and this is me again, I would say it's good to have 2 or 3 different jobs because that way you can try different things and keep yourself, you know, keep your hands in different buckets, try different things out, and you still have a steady income coming in. So if one thing doesn't work out, you can go to the next. Wow, silence.
Yeah, I would ask on that line, Dr. Tinwalla, that like what exactly, and this is a full disclaimer that that's not the area of like just my interest and like haven't explored ever and still don't intend to, but like what exactly do you do for Anthem? Like what does that work look like? Okay, so you know, during 9 to 5, Monday to Friday, I work for Anthem. I'm one of the medical directors. What we do is we do reviews. So we get the reviews coming in from inpatient and stuff, and we either approve or deny the care for the members. I work with the Medicaid members. So that's my 9 to 5 job. We, of course, interact with the hospital, with the states. We interact with the providers. There's a lot of phone calls we take during the day, but we also do a lot of reviews, okay? For medical necessity, basically. That's my 9 to 5 job. On the weekends, I treat sex offenders. So I do travel around the state. I go around as far down as East St. Louis, Carbondale. I do anti-androgen treatment. So I do chemical castration, so to speak. And I treat their psychiatric conditions also. So that's my other job. And then of course, IPS is a full-time job, by the way, but
It's a volunteer job. But I think just doing those two and then having some small gigs here and there on the side, which involve forensic work, I think it brings up enough revenue that I'm pretty happy. I would say I'm pretty happy with where I am in my life.
Thank you for that. A couple quick announcements. As Kristen mentioned, that there is a career fair that's about to happen through IPS. Please consider signing up and looking at all these options that are available. And number two is there are some seminars like this from last year, which also talks about contract negotiations and stuff that is important for a graduating resident fellow or even early career psychiatrists. Please reach out to Kristen or myself and we will point you towards it. It's also on the website for IPS. Please take a look at it. Now, any of the other attendees have any questions? If not, then let's go one round with all the panelists what is it that you want the ECPs to know at this stage in their life? Like if you're able to say, okay, if we could rewind time and say, you wish I knew this when I was an ECP. And words of wisdom, of course, please think about it. And of course, anyone else can answer that too. While you think on that lines, I will just ask one question quickly to Dr. May, who was one of our requested panelists as well. Dr. Amber May, question for you. You made a transition from a faculty position to private practice. So that was something that many ECPs were interested in. And how does that come about? Because some ECPs are interested in faculty positions, but also the very fact that okay, maybe I should have a side gig as a private practice, or like, I need to do something on my own as well. Is there any words of wisdom from you?
Yeah, thank you so much for giving me the opportunity to speak to that. Yeah, I will say I'd stayed on at my training institute at U of I. Loved the colleagues there, and my patients, and became the med director of the comprehensive ADHD clinic. And then with shifts in the pandemic, everything else, needed to figure out another means to another direction to go in. To be totally honest, if I was able to continue actively seeing clients in that role, I would have, but I think, with just the restrictions of academics, it was either kind of one or the other to see clientele. So I have continued on as volunteer faculties to edify those need for teaching and supervising and staying connected with my UIC crew. But I've been really very surprised by how easy the transition has been and how much I've loved the work. Had a couple of my clients who were able to, cross over with me from UIC. And then, first week I still remember it was the week of ACAP where I officially made the crossover. I've been fully booked ever since. So, and I'm just waiting for that time, of the flow to stop. And so it's so interesting. In serving, obviously, very high need population, south side of Chicago, west side of Chicago. I was worried, would I still feel that level of fulfillment? The level of pathology I'm working with in the North Shore of Chicago area has been as intense. And I feel, and there's still clients who call me saying they have spent, a year looking for a provider. And these are, folks with affluence and connections, and it's been tough for them as well. So I've been grateful to continue to find meaning in the work and kind of balancing that with continuing my volunteer ties to UIC. So been really grateful to kind of straddle both worlds, but have the autonomy of my hours. And so, clinic when I can set it up around my children's school schedule, and then some after hours. So having that flexibility, the locus of control, the financial compensation, has definitely made me grateful that I made the change, and And but it's been a great shift and continued on in the ways that I could.
Thank you for answering that. That covered a lot. Let's go back to the question about what would I want an ECP to know. Let's keep our answers to 1 minute or less, so we can hear from as many people as possible. That's the goal.
I'll go quickly. I had very good mentors who were very interested in what I was interested in, which is the community and community psychiatry, and so find those people, hang out with them. That would be the advice that I had. They kind of steered me. Like I said, I'm going to get boards in administration. They go, "Are you nuts? Why would you do that? Get boards in forensics. Go get a forensic fellowship." That was the best advice, because an administrative board is worthless, except an MBA. I agree with that.
So Dr. Johanna, I'll go after you if you don't mind. I think I totally agree with Dr. Johanna, getting the right mentor. And I think I want to put a plug in this point for IPS. Please get involved with IPS, because you have a lot of seasoned people who can mentor and help you guys out. So, we are here to help, but get involved so that we can provide that. My two other points is get an MBA if you think you are trying to do a business, trying to do any management. If you want to go up in the corporate world, I would say an MBA is definitely, I wish I had got my MBA 20 years ago. I would be in a different, I feel like I would have been in a different place right now. But having got one right now, I'm not going to say, it's been good. Let's put it this way. Lastly, I would say is artificial intelligence. And I know we don't talk about this, we haven't touched on this today, but I'm exploring artificial intelligence and digital health. This is the wave of the future. And I think if the ECPs and the med students and the residents have an ability to get involved, I think they should get involved at this time, because this is coming in the near future. So that's it.
When we started, everything was a piece of paper. So we didn't have such a thing.
So I agree with both Dr. Tinwalla and Dr. Johanna. I would say make a spreadsheet, research, talk to a variety of psychiatrists about their experiences. What did they do to get into their current positions, and then make an informed decision. And if for some reason, once you start something, you find it does not work or it's not meant for you, have the courage to move on. When I started that private practice in Chicago, I found that as a solo practitioner, even though I was in a group of therapists, social workers within the group, there were some 26 of them, plenty of referrals, but I was not getting paid the same amount for every patient, because they had taken the responsibility of connecting with the different insurance companies. And so I had to do 4 times the amount just to pay my malpractice and to stay there. So in 3 years, I decided, okay, this is not for me. I'm moving on. And that's when I joined the Federal Healthcare Center.
Yeah. Thank you for that, Dr. Hazaray. Dr. Wadyal.
If I could give a piece of advice to myself in the past, I'd say tomorrow morning, when you walk into the hospital, the clinic, or whatever entity you're in, go up to the janitor and introduce yourself. Introduce yourself to every tech. Introduce yourself to everyone in the building. The real way you build a career is you understand that team behind you actually feels like you're a leader, rather than someone who is on high. And if you do that, you'll find that you don't become that physician who only talks to physicians, but rather become someone who truly is well-rounded. I'd also throw in, make sure you have a hobby. Do not exclusively be a doctor.
Thank you. Dr. Janssen.
So I would say the hardest thing for the ECP, and what I would have told myself, is 1, you have more power than you think you do. but part of that power comes from knowing who you are and what you want, and being able to articulate that in an effective way as you're looking for jobs, right? Those of us that hire, right, we're going to hire people that fit into the roles that we want, which is not always aligned with what you might want to do. But at the end of the day, what we really want is people who are excited to be invested in the work and who can grow and build a practice that's really fulfilling. And so there's just, I think, a temptation as you're moving into your early career to just say yes to a lot of things that maybe you don't actually want to do. And so just learning to say yes to the things you should say yes to, but also recognizing why you're saying yes and what are the things that are really meaningful to you.
Thank you so much. Dr. Jasleen Singh is the RFM chair, and there is a mentoring program. Anyone that's watching this or will watch this, please make sure to connect with either Ms. Kristen Malloy or Dr. Singh, and they will let you know how to do the mentoring process. Also, for anyone that's offering to be a mentor, please, we love to have you on that program as well. I know you all have been doing that. We just would like for more people to have access to you. And for all the ECPs, have good mentors. IPS is a great way to do that. I got connected to so many of my mentors through the IPS, and organization is as good as its members. So more ECP members, residents, fellows, please make sure to get connected. No better way than your local district branch of your psychiatric professional society. Learn management if you can in the form of MBA or whatever. Keep up with your knowledge. Don't be afraid to say no. Have the courage to make a switch to something else if you feel the need to. Always be humble and be a team player. Have a hobby and strike that work-life balance. Know your worth and do not be afraid to say no. These were the summary that I wrote down. I hope I covered it all. Any final words from Dr. Weinstein?
Final words. I really just support using mentors, using networks, connecting. I mean, I grew up before social networking, so I'm not really so impressed with that. I think if you can use it to connect with people and have a one-on-one, it's much better. You get much better input than you, sorry to offend anybody who runs chat rooms here, but I think you get much better feedback than you will if you just put something into a chat room. And this is great. Thank you all for doing this.
And once again, to all the panelists, thank you so much. We will have more ECPs reaching out, and if they reach out, we will reach out to you as well. We are glad you're here, and thank you once again.
Thank you everybody for joining. Appreciate it.
Thank you, everyone.
Thanks, everyone.
Thank you.
Bye-bye.
Nice seeing you, Dr. Shenoy.
Thank you.
Thanks.